Yeah, and welcome everybody to our, I believe this is the fourth in our Distinguished Lecture Series. Really looking forward to our talk this afternoon. I want to just remind you of one upcoming event. On May the 23rd, Joe Palca, science correspondent for NPR, is going to be giving a fellow seminar in Dreyfus Auditorium at lunchtime. So if you haven't signed up for that already, please do so, because I think you'll find his talk on science in the media to be very interesting. Need to pause and just recognize that Prince passed away this afternoon, so everybody needs to listen to Purple Rain on the way home today. I'm going to turn it over to Suja Subramanian, who's going to now introduce our speaker.
Thanks, Don. It's a true pleasure to welcome Dr. Sankar. So Dr. Sankaranarayanan, I should say, but we all call him Dr. Sankar, and he doesn't seem to mind. So it's a real pleasure to welcome him here. I've had the pleasure of working with Dr. Sankar for almost a decade now, and it's been fabulous. So obviously, when I was asked to talk, I accepted very enthusiastically. It's always hard to keep it in the 5 minutes I'm allocated, so I'll certainly do my best. So firstly, for those who don't know him, he is the head of the cancer screening branch at the World Health Organization's International Agency for Research on Cancer. And obviously, in this role, Dr. Sankar wears multiple hats. So clearly, I'll begin with his seminal research. Anyone who works in the cancer world or cancer research, specifically cancer screening, knows about his work. His work is published in The Lancet, New England Journal of Medicine, and everywhere important. And he certainly had the foresight to begin the randomized clinical trials that are giving us the evidence today, decades ago. We're now seeing the fruit of all his work and all of the work of his collaborators come through, both in cervical cancer screening, looking both at visual inspection as well as HPV DNA testing, oral cancer screening. The only randomized clinical trial was initiated by Dr. Sankar, and more recently into his breast cancer work, which is growing more and more important, especially in the limited resource setting. So having said that, Dr. Sankar, obviously, for his multiple hats, the next hat is his policy hat. I don't believe he ever leaves a study without following through to make sure the evidence is implemented or working towards doing that. And actually, from my interaction with him, that's what takes up most of his time and travel schedule. So the fact that he remains so active, I've been told at least he can sleep anywhere at any time, but he's highly, highly productive, unbelievable given his travel schedules, and he's been instrumental in many of the policies that have been implemented, especially around cervical cancer, and continues to be today. And lastly, I couldn't leave an introduction of Dr. Sankar without mentioning his mentorship and his ability to bring researchers together. And there are several researchers in this room that Dr. Sankar has connected, and we're moving forward to do other research. So I certainly have to thank him a lot for training a whole generation of researchers around the world. So it's my pleasure to ask Dr. Sankar to come and deliver the distinguished lecture. Please welcome Dr. Sankar.
Thank you very much, Suja, for your kind introduction and kind words. I very much appreciate your help, your participation, and your assistance in economic evaluation of many of our projects, and thank the RTI, to give your services to us. Dr. Wayne, Dr. Bailey, Tim Hebel, Aaron Williams, Suja, and many of my colleagues here. I would like to thank you at the outset for the kind invitation and hospitality. I feel this is a real honor. And I also would like to thank Monica and Patrick for all the help they have been of. And so with these few words of introduction, I would like to go to the main topic, where I'll be just touching upon some of the important evidences which we have at the moment, basically from low and middle income countries. that is to an extent driving policies and implementation in different levels of health services in different countries. I mean, there's quite a bit of an optimism. The evidence will be further driving implementation. But from a health service perspective, one has to be highly patient because the health services are managed by managers who are not professionals, who are frequently transferred. There are a lot of challenges in implementing, generating evidence seems to be much more easier than implementing that evidence in the form of an activity within health services. So I salute the large number of health service managers who work under a lot of constraints, translating evidence into public health policies and implementing through mostly highly impoverished health services. That's a real challenge. I want to focus on few cancers here. The IARC estimates there are about 14 million new cancer cases every year in the world, of which about 8 million are in the developing world. And among these 14 million cancers, if you see, breast and colorectal cancers alone contribute to almost around 3 million cases, something like almost 22% of cases. Then if you add cervix uteri, the lip and oral cavity, then it goes up to 25 to 30%. And then there are other major cancers which I have not listed here, lung cancer, for example, liver cancer. So if you take about 6 or 7 major cancer sites, they contribute almost like 60 to 70% of the cancer burden in different parts of the world. So focusing on some of the major cancers always helps to drastically bring down the suffering and burden. It is not to say that many other cancers don't need attention, but to show some major impact, I think one has to focus on some of these major cancers. And cancer, as you all recognize, is highly heterogeneous. You have epithelial cancers, you have connective tissue tumors, and your tumors arising from lymphoreticular neoplasms, lymphoreticular tissues, and then from germ cells, and each of them have a highly different approach. Whereas for most of the germ cell tumors and lymphoreticular neoplasms, where diagnosis and management plays a major role, for connective tissue tumors, we don't know how to prevent, where management again makes a major role. For epithelial cancers, we are fortunate there are means to prevent them. And prevention seems to be one of the major approaches in controlling these cancers. So first, I would like to concentrate on breast cancer because breast cancer has become the #1 cancer among women in the world. And in many low middle income countries, it has surpassed cervix cancer as the #1 cancer. And it is actually increasing at a rate of 1.5 to 3.5% per annum. This is the annual percentage change at the moment we are seeing in low and middle income countries. Whereas breast cancer rates have plateaued off in the United States and some of the developed countries for reasons which are well to be understood yet, in developing countries, it is on the increase. And we don't understand much about the natural history of breast cancer. We don't have clinically evident precancerous conditions. Ductal carcinoma in situ is not clearly a well-established precancerous condition. And there are no effective means as of now to do primary prevention, even though we understand the set of risk factors which are associated with the Western lifestyle and less physical activity and hormonal exposures and things like that, which increases the risk of breast cancer. How to translate this knowledge to prevent breast cancers in people who have been already here, it's not very clear. If you look into the elements of breast cancer control, a few years back, chemoprevention with estrogen receptor modulators came up in a big way, and we will see, is it really possible to have this as a primary prevention approach? Then, of course, mammography-based screening programs, which we evolved since the late 1980s. And there is considerable controversy surrounding the mammography screening programs, how effective they are, and what is their role, and then is the overdiagnosis, how much it balances the early detection and the benefits which are associated with mammography screening. But from a low and middle income countries perspective, I wouldn't think too much about it because it is not simply feasible, because mammography screening requires substantial healthcare resources in the form of good equipment, radiographers, diagnostic radiologists, pathologists, surgeons, and to investigate people, anywhere between 4 to 8% of them, who are screen positive. So such resources, in the form of breast units are unaffordable in developing countries. So it is out of the scope of intervention in developing countries. On the other hand, we are not very clear whether we can go ahead and implement screening programs with clinical breast examination, screening of asymptomatic people. Although clinical breast examination is one of the most important diagnostic means to detect breast cancer early, but in a screening mode of asymptomatic women, we need further evidence to implement it in population-based programs. So there is a clear research need there. And then breast self-examination, again, at the moment, there is not much enthusiasm surrounding it. We will see this in a moment. And then another approach, which is very intuitive, is breast awareness and clinical early diagnosis, making women know what is normal for them so that they can, suspect anomalies and then empower them to go and seek prompt medical attention. And then empowering primary care practitioners, on people coming with breast symptoms, what are the differential diagnoses, and to improve their skills to provide a clinically validated, a clinically effective clinical breast examination. So what is their role? And I think such an approach has an universal appeal. It's possible everywhere. And of course, nothing works in breast cancer unless you have health services which makes diagnosis and treatment and follow-up care available and accessible and affordable. This is very critical. So in breast cancer control, detecting cancer quite early in stage 1 and 2, and then making the basic surgery available, the basic adjuvant therapies available from the health services, and then some very basic pathology facilities, a good quality hematoxylin eosin pathology, histopathology, plus at least a minimum estrogen receptor immunohistochemistry, to classify tumors as estrogen receptor positive and negative tumors, which have quite a bit of significance for the subsequent management. So, Tamoxifen. There have been several clinical trials. If you pool all the data from the clinical trials, it would indicate, of course, it prevents a certain proportion of estrogen receptor positive cancers. It has no impact on negative cancers. But if you look into mortality, there is no mortality difference. But it is associated with significant side effects, thromboembolic events, high risk of endometrial cancer, osteoporosis, pathological fractures. So some of the perceived benefits in terms of preventing estrogen receptor positive cancers are offset by the complications. So it doesn't have a favorable safety profile vis-a-vis its effectiveness. So it's not possible. And again, any prevention which involves a long-term administration of a drug, it has quite a lot of problems, keeping compliance, side effects, and all sorts of things. So, leave alone the efficacy, that is also another important consideration. So it is out of question. Then breast self-examination, a systematic breast self-examination where on a particular day in every month, the woman tests herself in a systematic approach to detect any breast lump or breast symptom, breast sign, and then seeking attention. One of the problem with this is, it may increase the anxiety of the woman. This is something, which makes them feel every month they do this and it becomes a practice. And it is not very clear, whether the benefits outweigh the harms. There was a major breast self-examination trial in Shanghai, which was done in industrial clusters, randomizing around 260,000 women. And half of the women were taught breast self-examination and half of the women in routine care. After 12 years of follow-up, if you see, in the intervention group, 50% of the breast cancers were detected in stage 1 with 135 breast cancer deaths. And in the control group, 45% in stage 1 with similar number of deaths. So the control group is mainly based on breast awareness. It's a good quality industrial health services there. So things like that. So essentially, if you look into a reasonable breast awareness, gives almost the same benefits as a systematic breast self-examination. And then if you also see the number of benign lesions detected and the number of biopsies performed, and all those things, an excess intervention, unnecessarily. So it is again not a policy to follow. Now coming to physical examination. Physical examination is probably the most important clinical skill in diagnosing breast cancers. The ability to feel breast lumps with the palm and the ability to assess the texture with the fingertips. And it has been shown, breast cancers, 1 centimeter and above can be detected with hand with a proper examination. But it is not only the lumps, there is an element of visual inspection of the breast, for changes in the nipple discharge, skin changes, and all those things also matter, skin tethering, nipple retraction, and all those things. But in follow-up studies, it has been clearly shown the single most important pathognomonic sign on clinical breast examination is lumpiness or lump in the breast, followed by an unilateral bloody nipple discharge or unilateral nipple retraction. And in fact, 95% of the breast cancers detected by clinical breast examination are associated with the lump, and only about 5% with other breast symptoms. So, one of the important triaging procedures in a following clinical breast examination when one has a high degree of clinical suspicion of breast cancer is the so-called triple testing or triple diagnosis, which involves an expert clinical assessment with clinical breast examination. So at that level, one may exclude few people, okay, there is nothing wrong with you. Following which, one of the diagnostic imaging, either diagnostic mammography or diagnostic ultrasonography. People don't realize, quite often people always confuse between screening mammography and diagnostic mammography. Diagnostic mammography is a very important component of triple diagnosis in triaging people with breast symptoms and breast lumps. So this has to be very clear, particularly in women above the age of 50 years. But in younger women, particularly between 30 and 45 years, and women with big breasts, ultrasonography, diagnostic ultrasonography, has a major role in the early diagnosis of breast cancer through the triple testing procedure. So at this step, you should be able to eliminate few number of women saying that, oh, there's nothing wrong with you. And then finally, tissue sampling, either with fine needle aspiration cytology or with core biopsy. But in the case of low and middle income countries, core biopsy is unaffordable because the equipment is anywhere between, say, 50 euros to around $150, depending upon where you live. But fine needle aspiration cytology, there is enough evidence from clinical studies, fine needle aspiration cytology using a 27 gauge needle and a 10 cc syringe under ultrasonography control or even visual control, provides a very good diagnostic step in triaging breast lumps. And in fact, we would say very confidently a triple diagnostic procedure among women with clinically suspicious breast signs has an excellent sensitivity and specificity. Now, the issue is, okay, we all understand if somebody has a clinical symptom, clinical breast examination is very useful. But can we take it as a screening procedure in people, apparently healthy people, and then do clinical breast examination? There have been 3 major trials looking into clinical breast examination. The first trial was in Philippines, which was organized by the IARC in the 1990s, randomizing almost 400,000 women. But the trial failed because after the first round of screening, and at that time in the Philippines Health Services, any interaction for cancer diagnosis and management has to be out-of-pocket expenditure. So only 20% of the screen-positive women were able to access health services for diagnosis and management. So there was an ethical issue, so the trial was discontinued. Now at the moment, there are 2 major trials ongoing in India. One is in Mumbai. This is the old published data. I have the new data with them. This is a study which has randomized around 150,000 women in Bombay slums with clinical breast examination provided by trained health workers once in 2 years. It is clearly showing a stage shift, a significantly larger number of breast cancers are diagnosed in stage 1 and 2. The mortality differences are yet to emerge. And there is another trial in southern Indian state of Kerala in Trivandrum, which is again organized by the IARC in collaboration with the regional cancer center there, which has randomized around 150,000 women, and half of them randomized to clinical breast examination by nurses, trained health workers once in 3 years. And in both the trials, if you see, it results in referral of around 4 to 5% of the women in each of the rounds as having an abnormality, breast abnormality. So that requires about 4 to 5% of the women, screened women, should have access to triple diagnosis. So within the health services, those facilities should be available. And then if you look into the positive predictive value of clinical breast examination, it is like anywhere between 1 to 5%. For every 100 abnormal clinical breast examinations, you detect 1 to 5 women with breast cancer, with 95 women having benign breast lesions or nothing abnormal. So one has to look into the anxiety and everything associated with that. But certainly, both the studies show there is a significant early detection of breast cancers in stage 1 and 2. We will call stage 1 and 2 breast cancers early cancers, even though stage 2 is a highly heterogeneous condition where some of them have movable lymph node metastasis and some of them have no lymph node metastasis. But stage 1 and 2, provided there is good access to treatment, the survival outcomes are similar. There is good evidence from prospective studies to that perspective. In both the studies, the mortality differences have not yet emerged, but a subgroup analysis recently shows mortality differences may be emerging for women between 50 and 69 years. I don't know why, in mammography also you see this, in clinical breast examination studies also this evidence is now emerging. So what characterizes this 50 to 69 women having a better outcome with the screening? It's unclear. And then if you see this, if you look at this in stage 2, if you look into case fatality, the case fatality of stage 2 is not very different from the case fatality of stage 1. And in fact, there's a big difference in case fatality as you move to stage 3 and stage 4. Actually, if you see the 5-year survival in stage 1 and 2 cases in both the studies, in Mumbai study and in the Southern Indian study, is around 92%. And much higher with estrogen receptor positive cancers. And then there's another important study in Mumbai, which is a cohort study, which looks into the efficacy of breast awareness, creating breast awareness among primary care practitioners, as well as among women in early diagnosing breast cancer and improving survival and mortality. So this involves around 35,000 women who are systematically taught, given messages on breast awareness, encouraging them to assess their breasts and then to have an idea what is normal for them. And whenever there's an abnormality, to seek services. So in that context, I think very quickly, over the years that we have seen after the intervention, there has been significant improvement in early detection, a significant improvement in the proportion of cases requiring breast conserving surgery. And more estrogen receptor positive cancers are diagnosed by these early detection methods, so that there is lesser proportion of women requiring adjuvant chemotherapy, more proportion of women requiring adjuvant hormone therapy with tamoxifen. And those things are emerging. Actually, this seems to be quite interesting. In fact, in developed countries, even before the introduction of mammography screening, there has been significant improvement in survival from breast cancer. And we think that could be due to the breast awareness. Mammography screening became widespread since 1985, 1988, those regions. And in fact, if you look into some of the data coming from Connecticut Cancer Registry in the United States, there is substantial evidence, to support breast awareness as a major intervention for breast cancer control. And in fact, we think at this moment, this will be an important intervention for countries, particularly low-income countries, where one has to beef up health services gradually. At the same time, you have to apply something which for early detection of breast cancer, which increases the burden of disease for health services very gradually. Now, colorectal cancer follows breast cancer. Breast cancer increases, colorectal cancer increases. In Singapore, when Singapore became independent in 1967, there was no colorectal cancer in Singapore. Now, colorectal cancer is the #1 cancer among men in Singapore. In South Korea, Singapore, Hong Kong Special Administrative Region, Japan, everywhere colorectal cancer has become #1 cancer among men and #2 cancer among women. And this is due to this rapid lifestyle changes, socioeconomic development, less physical activity, everybody running around in 2-wheelers and 4-wheelers, nobody walks, and nobody does household work, and all McDonald's, Kentucky Fried Chicken, everything is available, So less physical activity, sedentary lifestyle, Coca-Cola, and everything. So there is very good ecological evidence, this lifestyle changes. So in Africa, we should prevent this, because in Africa, still colorectal cancer is very low. In South Asia, it is very low. But it is increasing, again, at an annual percentage change of 1 to 2%. So this will become a major cancer soon. But we can prevent it if we learn from what people did it in, in East Asia. But we never learn. Okay? Yeah. For colorectal cancer, fortunately, there's not much of controversy about screening. Screening is a very effective intervention for colorectal cancer. We have several screening tools. The fecal immunochemical vocal blood testing is a very interesting option, which can be readily incorporated into primary health care, because the qualitative tests are very affordable, and it is possible to do, and it is real time, and it gives quite a lot of very useful information on the risk profile of people. And then it is possible in health services, to set up triaging colonoscopy, because whenever there is a fecal vocal blood test screening, then to investigate the screen positive people, you need good quality diagnostic colonoscopy. This is often seldom recognized. It has to go hand in hand. Unless this doesn't go hand in hand, then you won't be able to perceive the benefits of introducing fecal vocal blood test screening. I'm not talking about screening colonoscopy. There are only 2 countries which do screening colonoscopy, which is United States and Germany. It's not possible in developing countries. We should not go anywhere near it, because it requires substantial resources to do screening colonoscopy. On the other hand, diagnostic colonoscopy, when you do fecal vocal blood testing with the immunochemical test, the positivity rate ranges between 1% to around 3%. And it is possible to set up diagnostic colonoscopy services where these people can be effectively triaged. And again, in diagnostic colonoscopy, quite often it ends up as a therapeutic colonoscopy, because there are the endoscopic mucosal resections, for stage 1 and stage 2 tumors, which can effectively replace resection. And actually, this is one area where East Asia is very advanced. The Japanese were much more advanced than anywhere else in the world 10 years before it became popular in Europe and other places. And such skills, it is possible to build up among colonoscopists. In addition to providing diagnostic colonoscopy, the ability to intervene to do endoscopic mucosal resections, endoscopic resection of polyps, especially advanced adenoma, because advanced adenoma is something which is more than 10 millimeter in size, or it has severe dysplasia, or it has a tubulovillous pattern. And the diagnostic colonoscopy is so advanced with the digital imaging, you will be able to predict severe dysplasia within polyps. And then removing the advanced adenomas is highly protective. The advanced adenoma, I would say, is the CAN3 of colorectal cancer. You manage 100 people with advanced adenoma, you are preventing 50 people with invasive colorectal cancer in the next 10 to 12 years. So this is one area where both prevention and early detection will work. So a few years back, when Thailand was contemplating what to do to, in Thailand it is increasing, colorectal cancer is increasing, it's following Singapore. So they wanted to implement colorectal cancer screening as a pilot project in one of the provinces through the primary health centers. Where people will go with their fecal sample, the nurse will test in front of them, and if the test is positive, the people will be referred for diagnostic colonoscopy. And the de novo diagnostic colonoscopy services were set up in the regional cancer center there. And it was very interesting because this targeted around 130,000 people between 50 and 65 years in the Lampang province. And almost about 70% participated in screening. And the screen positivity rate was around 1.1%. And when you look into the detection rates of polyps, detection rate of advanced adenoma, and detection rate of early stage colorectal cancers, they were exactly comparable, similar to the pilot programs which Australia introduced and Britain introduced before scaling up colorectal cancer screening. In fact, cervix screening was just organized like this, and breast cancer screening was organized, but colorectal cancer scaling up is going in a very systematic way. And any screening program, colorectal cancer screening now clearly shows it takes about 10 to 15 years to stabilize. So from this pilot program, the Thais now are scaling up in a phased manner in the other provinces. So now they have scaled it up in about 5 more provinces. So the national scale up will take around 5 to 8 years in Thailand. So what I'm saying is this is one of the interventions which can be integrated in the primary healthcare services. Because in WHO's NCD integrated control mechanisms, one of the things is to take cancer control to primary care. So one of the interventions which can go into primary care is fecal occult blood testing. Now, coming to oral cancer. It is not a huge problem in many parts of the world, but in certain regions of the world, it's an important problem. For example, if you take South Asia, India, Pakistan, Sri Lanka, Bangladesh, Myanmar, southern Thailand, and the oceanic islands, all the Pacific islands, Taiwan, in all those places, oral cancer is a major problem. And in certain regions in South America, Uruguay, Argentina, and places because of the meat drinking, oral cancer is a problem. And tobacco and alcohol are overarching risk factors, and with tobacco and alcohol control, you should see substantial reduction in oral cancers. For example, in eastern France, in the Bas-Rhin region, Strasbourg and all those places, oral cancer used to be #1 cancer about 30 years back because of heavy alcohol drinking. And over the years, the French consume less and less alcohol. The per capita consumption in France has come down drastically. And in fact, about the oral cancer incidence rates have fallen by 70% in the Bas-Rhin region, which has been clearly shown by cancer registries. But unfortunately, we have not seen big changes in tobacco consumption, despite several years of tobacco control initiatives in many of the high-risk countries in the South Asian region and the Oceania. So, but on the other hand, a stage 1 oral cancer is highly curable. A stage 1 oral cancer is as curable as a stage 1 breast cancer, 95% 5-year survival rates. And it is less than 2 centimeters, no nodes. And in head and neck cancer and in oral cancer, when the disease spreads to the lymph nodes, practically everything is lost. Even the most advanced therapeutics won't control people in whom the disease spreads to lymph nodes. So you have to get these people before the lesion spreads to the bones or the skin or the lymph nodes. And then again, oral cancer has fortunately highly visible oral precancerous lesions like white patches, leukoplakia, red patches, erythroplakia, and a specific condition in which there is considerable fibrosis of the mouth, oral submucous fibrosis. So it is possible, you don't need any endoscope or anything to do a oral visual inspection, open the mouth under good light and then you can see the lesion looking at you. So we implemented a randomized trial in southern India, randomizing around 200,000 people, half of them tobacco users and alcohol users. And then we showed something like a 30% reduction in incidence and mortality following 3 or 4 rounds of screening once in 3 years. And then we also showed there is substantial benefit in people who comply with repeated rounds of screening. And in fact, if you see, the mortality reduction is around 80% in people who comply with all the 3 or 4 rounds of screening, and with significant incidence reduction, because it detects oral precancerous lesions, you direct biopsies, and people stop habits, and there is a benefit out of that. But on the other hand, where cervix cancer, the dysplasia is limited to the transformation zone, you can either ablate the transformation zone or you can excise the transformation zone. In oral cavity, it is not possible because the entire oral mucosa is carcinogenic, and then quite often the lesions are extensive. So precancerous lesions, surgical intervention is very difficult. So one has to rely on assessing the level of dysplasia there and then focusing on habit cessation. Anyway, and this is one of our first studies where Suja helped us to do the economic analysis, costing the different interventions and then showing that it is a highly cost-effective intervention among tobacco and alcohol users for oral cancer prevention and control. And in fact, this economic evidence is now driving public health policies in countries as well as for WHO. Now, the last component is coming to cervix cancer. This is the most preventable cancer, but yet not prevented. So that is the tragedy about cervix cancer. We understand the natural history very well. I don't think we understand the natural history like this in any other cancer site. So, such an extensive work which has happened over the last few decades. And one of the most cardinal developments in cervix cancer prevention is the identification or the establishment of persistent infection with one of the 13 high-risk types of human papillomaviral infection as the necessary cause for cervical cancer, which means without the infection, cancer cannot occur. I think that is one of the great developments in oncology in recent years. And in fact, it is a very important biomarker for cervix cancer risk. In any woman who has a HPV infection above the age of 30 years is likely to be a persistent infection, and she is at high risk for cervix cancer. But if you look into pure statistical terms, it is an ubiquitous infection. Almost everyone gets infected, especially after sexual debut. And fortunately, it clears in about 90% within 3 years. So in most of the people, if you test them in their 20s and mid-20s and early 20s, they'll be infected with HPV, but it clears. But in very few women, it persists. And in fact, in statistical terms, cervix cancer is a very rare long-term outcome of a very common ubiquitous infection of the surface epithelium of the genital tract. And in fact, 1 out of every 10,000 women who are infected with HPV will develop cervix cancer in their lifetime. So it is a very rare outcome of a very common infection. So there is the opportunity, and that is the challenge as well, because you have to intervene in a large number of people if you want to prevent this very small proportion developing cervix cancer. And it is very clear it is a disease of the poor women. It is associated with low socioeconomic status. It is very, very clear. Poverty is a major driver of cervix cancer risk. And this is one of the reasons, with the ensuing socioeconomic development in many countries, you will see a slow fall in cervical cancer incidence rates. In almost all countries, with the exception of certain East African countries like Zimbabwe and places like that where there is a very high HIV epidemic, Uganda, Zimbabwe, and all those countries, where there is an annual increase in cervix cancer risk. And as well in some of the East European countries because of the collapse of the screening programs. In all other regions of the world, in Latin America, in South Asia, in East Asia, cervix cancer is falling at a rate of 1 to 2% per annum. But after some time, it reaches a plateau. But the message there is, this type of fall is being used by people to hamper intervention. Because people will say, oh, it is falling, why should we intervene? But people don't realize introducing additional interventions will make this fall very rapid. And literally, cervix cancer is potentially could be eliminated. And I'm sure at least some of the small countries will show elimination of cervix cancer in about 3 to 4 decades if they have an effective HPV vaccination program and an adapted screening program. I'll say what is an adapted? It's not over screening, just like what we do in the United States and Germany. It has to be something which is very focused, cost effective, very infrequent rounds of screening. We will see this in a moment. So we have several opportunities for cervix cancer prevention now: socioeconomic development, women's empowerment, HPV vaccination, screening, early diagnosis and treatment. This is one cancer where the treatment methods are highly standardized. There is not much controversy about things. So we would say very confidently, with the current intervention, the elimination of cervical cancer is possible. And actually now in South America, many countries have joined in a program with a political slogan, eliminate cervical cancer in South America. Okay. HPV vaccination, efficacy, safety, there is good evidence. Okay. And in recent years, there has been from both in clinical trials as well as from routine programs in India and in Costa Rica, and in focused clinical trials in Canada and Europe, it was shown that a 2-dose HPV vaccination is as effective as a 3-dose vaccination in young girls. So following which the WHO changed the recommendations, recommending a 2-dose vaccination 6 months or 1 year apart if vaccination is initiated prior to 15 years. And recommending the 3-dose schedule only for those women who are more than 15 years of age, or in immunocompromised girls and women like HIV-infected women. So this has been a major development in improving the possibility of implementing HPV vaccination in countries. And similarly, HPV vaccine became the Gavi-eligible vaccine very recently, which is also driving the implementation of HPV vaccination programs in countries. Despite all this, it is facing considerable challenges because there is considerable misinformation on moralistic grounds, on several things. I think no vaccine has undergone this much of, sort of opposition and advocacy against intervention, against implementation like HPV vaccination. It is so much of resistance. And what is very striking, even among informed medical personnel, medical establishment, there is considerable opposition for the implementation of HPV vaccination in many countries. But despite that, the good news is it is being rapidly implemented. And if you take hepatitis B vaccination, it was invented in 1982. And by 2004, only 4 developing countries have ever implemented hepatitis B vaccination in the national immunization programs. By that time, 33 developed countries implemented because they had the resources. 2004, it became a Gavi-eligible vaccine, and that made the difference. In the next 10 years, the next 6 years, almost 100 developing countries implemented hepatitis B vaccination. Now we have like 182 countries. Human papillomaviral vaccine was licensed in 2007. By 2015, December, there have been 80 countries which have implemented in national immunization programs, of which 33 are developing countries. And about 23 countries are implementing HPV vaccination as a pilot program, as a prelude to national scaling up. And actually, if you see, very striking, if you see the Latin Americas, the region of the Americas is the most successful region in implementing HPV vaccination. In fact, 7 out of 8 girls in Central America and Latin America have access to HPV vaccine through national immunization program, thanks to the foresight of the governments and the PAHO revolving fund, which bulk purchases vaccine, negotiating the price and distributing vaccines to national immunization programs. Because this region will show the impact first than any other region. Just like Taiwan, which was the first country to implement hepatitis B vaccination, which is already showing a 70% decline in hepatocellular carcinoma in people less than 25 years of age, the cohorts which have received vaccination. Okay. And then it is also very interesting to show by observational studies recently in all those countries which implemented early, like Canada, United States, Australia, and Denmark, and places like that, there is already significant decline in HPV vaccine-targeted infections among vaccinated people. There is lesser frequency of genital warts. There is a lesser referral to colposcopy. There is something like a 50 to 60% reduction in CAN3 frequency in young girls who are being screened, because policies in those countries screen young people. So already the evidence is emerging, even with something like a 50% coverage. If you see all the developed country programs, the third dose or the second dose coverage is less than 50%. But in developing countries, the coverage is much higher. The second dose or the third dose coverage exceeds 80-85%. But there is evidence emerging now. Even one dose may be very interesting, because some of the default studies in Costa Rica and India show one dose, the HPV infection frequency following one dose is exactly similar to that of 3 doses. So this could be because the body may be thinking this vaccine is like a vaccine which resembles the infectious agent. So it induces a large number of long-acting, long-surviving plasma cells which have the vaccine memory for many years. So it's all interesting. So what is the significance? In future, as the HPV vaccination is implemented, there will be successive cohorts of women who are going to be at low risk for cervical cancer. At very low risk, because they have very low frequency of HPV infection. There is considerable cross protection. So the screening programs have to adapt. The screening programs have to mostly rely on HPV testing, which is very objective. Subjective tests like visual inspection with acetic acid and cytology will have great problem, because the prevalence of disease will be very low. There will be overcalling, sensitivity will suffer, specificity will suffer. And in fact, some of the very early evidence for the efficacy of HPV DNA testing came from developing countries. In South Africa, our colleague Lynette Denny showed in a screen and treat setting, where you screen people and the woman is screen positive, if there is no clinical evidence of cancer, you treat the cervix, either with cryotherapy or with thermoablation. So she showed in such a setting, in a randomized trial, if you do HPV testing and then treat people who are HPV positive, you can reduce the frequency of CAN3 lesions by 75%. And if you do visual inspection with acetic acid, my colleague Grasbeck is here, he's very experienced in implementing this in Zambia. Where you apply acetic acid, 5% acetic acid, and if there is a lesion, a white lesion developing within 1 to 3 minutes after application, the test is positive. It's a real-time test. Even in such a low intensity, low technology screening, a VIA screen and treat will reduce cervical CAN3 lesions by around 35%. Then 2 studies in India, a randomized trial in southern India and another randomized trial in Bombay, showed with visual inspection screening provided by nurses, one can reduce cervical cancer incidence and mortality by 30%. Long back, WHO in one of the modeling studies showed if you have a once-a-lifetime cytology with 100% participation, which never happens in practice, and with the 100% compliance to diagnosis and treatment, you can reduce cervical cancer incidence by 35%. For the first time, these studies showed a low-intensity screening can reduce mortality. And then in another randomized trial in India, which showed a single round of HPV screening can reduce cervical cancer mortality by 50%. And women who are HPV negative are at very low risk for cervical cancer in future. And in the same study, with a head-on comparison with cytologists, compared to cytology, HPV testing, a single round of HPV testing reduced mortality by 30%. These are studies with a long-term follow-up using cancer registries and things like that. And then this study actually randomized around 142,000 women and followed them over 15 years. And in the same study, we showed that women who are HPV negative at baseline with a single test, their risk for cervical cancer in future is extremely low. It's a very high negative predictive value. Actually, at the moment, with the increasing implementation of HPV vaccination, one of the important philosophies is reduced frequency of screening. We would say in the context of developing countries, even a single round of screen between 35 and 39 will be sufficient. I mean, the topic is very in a lot of flux now. So finally, I wanted to show one example how research evidence leads to policy and implementation. The southern Indian state of Tamil Nadu, the randomized trial with VAA showed a 30% reduction in incidence and mortality. Then taking the evidence, the state government wanted to implement cervix cancer screening using visual inspection with acetic acid through the primary healthcare services. And this state has a high risk of cervical cancer. If you see this picture, most of the districts have cervix cancer as the #1 cancer among women. Only few districts have breast cancer as the #1 cancer. So they went ahead and implemented. They trained a lot of primary healthcare nurses, improved the infrastructure in primary healthcare. There are a lot of collateral benefits in implementing an intervention because people always look in terms of reduction in incidence and mortality. There are a lot of other benefits in terms of better waiting places, better infrastructure, better lighting, and better medication available. There are more personnel available in primary healthcare services. So all these benefits the state enjoyed. And in a program, this program was implemented with education and all those things. So this shows the monthly recruitment of women into the program. And interestingly, in many developing countries, when they implement screening programs, there is no information system. This is the biggest problem. In Latin America, 40 years of cervix cancer screening, there was no information system, so we didn't know what was going on. But this program, right from the beginning, built up an online information system from every primary health center. Data were captured real time into a central data capturing data management place. So at any point in time, you know what is really happening. How many women were screened? How many women were positive? How many women went for diagnosis? How many women went for treatment? And all those things. And in fact, they were able to show, the program targeted around 14 million women aged between above the age of 30 years. And the program actually covered, they claimed 11 million women. But I would think it is 11 million tests. So we have to see, because some women may have come repeatedly. But anyway, for a routine program which has been introduced in existing health services, I think many of these input measures were really impressive, indicating the scope for the program to improve in future. And my colleague, Grasbeck is here, has been a lot of experience in Zambia in scaling up visual inspection screening with the digital cervicography. And in fact, the Zambians are planning the national coverage, in few years' time. And there are several examples. I just wanted to show one example. And then the future of the cervix cancer screening is in HPV testing. I think in Netherlands is showing the way now. Netherlands is going for primary HPV screening beginning at 30 years. Then 3 rounds of screening at 5 years, and then another 2 rounds of screening at 7-year interval. So total between 30 and 65 rounds of screening. Australia has again shifting to HPV screening after the implementation of the HPV vaccination program. So the future is HPV screening. And Argentina is taking lead among developing countries along with Mexico. with planned introduction, with piloting in one of the provinces, and then they are scaling up with HPV testing, which performs really well in routine settings, and using the existing cytology establishment for triaging HPV positive women. So if you look into the post-vaccination scenario, the basic message is you have to critically revise your screening program, and the screening program has to be low intensity, and it has to be based on HPV testing. So from my group, this is not a WHO policy, this is not an IARC policy, so we say in every country where we work, one of the pragmatic ways of approaching cervical cancer prevention is vaccinate a single year cohort between 9 and 13 years. So we prefer like 11 or 12 years. At least provide a single HPV screen at the ages 35 to 39. Here, the technology has to match. I think the real bottleneck for HPV screening now is we need to have affordable tests and affordable, much more real-time, simple tests which we need for HPV testing. That's a real challenge here. There are more than 600 tests available in the market, and choosing a test is a real issue. I think I stop here. Thank you very much for your attention. I wanted to show a tiger. This tiger was actually, I took the photograph of the tiger because I was searching for the tiger for many years. Right? And in fact, at the beginning of the 20th century, there were 100,000 tigers in the world, and which reduced to around 1,200 tigers about 10 years ago because they were all hunted down. And if you see a tiger, you can understand why it can be easily hunted, because after a meal, it always walks in an open road very slowly, it doesn't care about, so you can easily shoot them. It's very sad, actually. And in fact, among the tiger regions, now Siberia and India are the only places where there are tigers in significant numbers. In Siberia, around 400 tigers, in India, around, at the moment, its population is increasing, around 2,000 tigers, and then few tigers in Bangladesh, Nepal, Myanmar, and Thailand. And in fact, there was a recent tiger census. They showed the tiger population in India has almost doubled. It's a good news. I think in a globalized world, we never think about animals, we never think about flora and fauna. We all think everything is for the human being. I think we should realize that ecology has a major role. So when I see the campus here, I was very much impressed. With a lot of greenery, trees and open space and good oxygen. Thank you very much for your kind attention.
Thank you, Dr. Sankar, for taking us through 4 cancers so broadly and certainly updating us. We're open to take questions. Well, Dr. Sankar is open to take questions, I presume. But please use the microphones.
Good afternoon, Dr. Sankar. Thank you for coming and giving us a wonderful lecture. I was on the call yesterday during the interactive discussion. My name is Delisha Stewart. I work at RTI in the Systems and Translational Sciences group. And I discussed briefly that one of our goals is to identify global biomarkers to see how cancer changes across global populations. And so I'm interested, I understand some of the things you talked about yesterday, challenges toward working in low and middle income countries. But again, with our goals, how do we access or work with you to access those biorepositories of samples that may be serially collected from groups of women pre-cancer diagnosis and up into a cancer diagnosis, so that we can begin to develop some of these low-tech or low and quick, easy to interpret, cancer screenings or definitive diagnostic test?
Thank you very much for that very interesting question. And in fact, as you rightly said, the biological specimen repositories are very important for disease control, for identifying biomarkers and all those things. But the recent challenge in accessing biorepositories in many countries has been the border controls in transferring specimens. Because now countries are increasingly suspicious, including Africa, every place, because the national governments have a lot of restrictions on transfer of biological samples from one country to another country. So in such a situation, these countries would require, whatever biomarker studies or whatever studies that one is contemplating, a genuine researcher is contemplating, has to be done within those borders. This is one way of bringing technology in the reverse way, because in developing it, yesterday we were talking about the post office research. People used to call, you collect biological samples and then they go to a sophisticated laboratory abroad. And then so the way to go forward in using biorepositories is to go the other way around. Collect specimens, and whatever you want to study in those national boundaries, or in a place where this is possible, a group of countries join together and then do this. The agency has a large amount of biorepositories from European countries. We have a large investigation called the European Prospective Investigation into Cancer, where a large number of biological specimens have been collected and used, and it's available for genuine researchers. But when they devised this program, they were very clever, because the way the informed consent process was implemented so that the samples can be used for a variety of studies, because this is another thing we need to take into consideration. Because people who provide the biological sample may not be living. So all these issues have to be taken into considerations. So you have to think taking studies into countries where you are collecting your specimens.
Hi, I'm Susan Sumner, and I direct what's called the Systems and Translational Sciences Group, and I really appreciate your presentation. I wanted to tell you that the group that I direct and where Delisha works, we are part of the NIH Common Fund program, and one of our goals is to promote clinical and translational research using the resources from this NIH Common Fund program that has been developed by 6 centers across the United States. And one aspect of that is to provide training both within the United States and globally. And there's a considerable amount of funding through this NIH Common Fund program to take what we have developed as biomarker discovery tools into global health, and to provide that training globally, and to do these kind of studies in populations across countries so that we can get the most relevant biomarkers and gain the most mechanistic understanding. And I really do feel that this is really important, because these non-invasive biomarkers that we could detect using urine or saliva or feces will definitely be the kind of markers that we can kit to be able to use in low and middle income countries. So any way that we could collaborate through that, and we could definitely attract funding from the NIH Common Fund for those kind of collaborations. So we should think about that more.
Thank you.
Thank you for a wonderful talk. Nimi Ramanujan from Duke University. There has been a public health recommendation for colon cancer in the last year, I think in September, that aspirin is an excellent preventative drug to take. And moreover, it's no longer just epidemiological evidence. There's actually mechanistic data that says that aspirin, in fact, doesn't work for every cancer, but in some cancers it works better than others. And now there's a study in Dana-Farber where they're using aspirin in women with breast cancer, actually as part of an adjuvant therapy. So I'm just wondering, given that aspirin is ubiquitous, presumably, and assuming it's authentic, what do you see the prospects for that being disseminated in a global community where, there is a real chance to use something very simple for prevention?
Aspirin has been used extensively in cardiovascular disease prevention, But if you take from a preventive perspective, I don't think there has been any recommendation, public health recommendation, that people, okay, above the age of 50 years, you take 80 milligram of aspirin every day. Not such type of recommendations have evolved even for, but on the other hand, it is being increasingly, under medical control, by doctors and things like that, you prescribe and, that is the most extensive level at which aspirin has been used or is being used in countries, especially in people who have cardiovascular events, already cardiovascular events, or those people who are at very high risk for cardiovascular event. And another example is statin. The discussions and the argument on the routine use of statins in preventing cardiovascular illness. So similarly, I am not so sure, how one can translate this into a routine recommendation of apparently healthy people using low doses of aspirin for prevention of, cancer. Again, this type of interventions will require some careful intervention studies with a long-term follow-up to establish the benefits as well as the associated harms.
Just a follow-up, even though it is now recommended in the U.S. and it's a policy that doesn't necessarily translate to other countries.
Yes.
It has to be revisited every time a new country thinks about, considers this. Okay.
Exactly. Because if you recall the beta-carotene story, the beta-carotene at one point in time, people thought it is a magic bullet. But the randomized trials either showed no evidence for benefit or it even showed harm. So it totally disappeared from the scene. Yeah.
Dr. Sankar, I wanted to thank you very much. That was a tremendous talk, and for us here in the room, but for probably 3 or 4 number of people who were watching the video stream, and perhaps there will be questions from them, I don't know. But I wanted to bring you back to the HPV and cervical cancer issues with 2 or 3 kind of related questions, because I thought your data and presentation made a very strong case for the HPV vaccination. One question I had is that really mostly aimed at girls and women and not boys or men?
Yeah.
And is there ever any thought of going beyond, the women and girls? The second question is whether you actually can move the age, at least for girls, down younger, so that at some point would this vaccination ever be one of just a battery of what essentially are childhood immunizations? And whether also there could be studies showing whether just one might be sufficient, or one and then a booster 25 years later. And finally, I'm wondering whether all the work that's been done in low and middle income countries on this this sort of intervention excuse me, provides lessons back for highly developed countries and the US in particular.
Thank you. I think the current WHO recommendation for HPV vaccination is only for girls. The reason the reason for this is, first, when we considered HPV vaccination initially, the costs were much higher, right? So cost was a major, the vaccine unit cost was a major barrier. I mean, leave alone the distribution or the vaccination costs, the field costs, which are much more higher than the vaccine costs. So if you target boys in addition to girls, then the cost of implementation of the vaccination program is prohibitive. Because of the unit cost of the vaccine, as well as the cost of actually vaccinating people. And the second thing is, in vaccinology, herd immunity is a major contributor. So by vaccinating a large number of girls, you are inducing herd immunity, and the herd immunity will protect, the boys and the men. And then looking into the cancer spectrum, even though men are as frequently infected as women, if you look into the cancer spectrum among men as compared to women, the HPV-induced cancers, the burden of HPV-induced cancers among women is quite high. As of now, there are only 2 countries which have a policy for vaccinating boys. One is Australia and the United States. And no other country is contemplating vaccinating boys. And I don't think this will change for a long period to come. Yeah. But this is one topic which is increasingly being discussed. Now, coming to the 1 dose, the people who received 1 dose by default in the clinical trials of the vaccine, which of course was never published, and people who received 1 dose by default in the Costa Rica vaccine trial, and as well as in one of our studies in India where vaccination was suspended because of misinformation and things like that, we have ended up with a large number of girls receiving 1 dose. In all these studies, it shows the protection offered against vaccine-targeted HPV infections were exactly similar to 3 doses and 2 doses. And then interestingly, even though the antibody levels are inferior to 3 doses, the avidity of the antibodies is similar. The 1 dose antibody is as avid as a 3 dose antibody. So we having not, at the moment we do not know what threshold levels of antibodies are required to protect against HPV. So this is an interesting option, but I understand now the NCI is already planning a randomized trial to compare 1 dose vaccine with 2 doses of vaccine based on this observational evidence. Yeah.
Well, I'll ask the last question, and then I know we're going to have a reception afterwards, and I know you'll be available to answer additional questions from people. So you opened yourself up to this question at the very beginning when you said, we know a lot of things that people don't end up implementing.
Yes.
So we know that's, of course, true across many other things that we all do. We found a lot of great data. We can prove the efficacy of different things.
Yeah.
And why people don't do them is a complicated question. Yeah. Obviously ranging across diseases or across countries or across policies. Kind of stepping back now from your career, do you have any thoughts about what are the major barriers to moving from research to practice? There might be some lessons learned from what you've been doing?
Yeah, I feel quite incompetent to answer this because this is $1 million question. But on an optimistic note, I think time is the answer. Grasberg, you will agree with me. 30 years back, we did not know what to do for cervix cancer prevention in the third world. Then all these studies looking into visual inspection, HPV testing, see and treat approach, single visit approach, they were all initiated around 1995 and generated the evidence over the next 10, 12 years. But it is actually beyond 2008, the countries really looked into implementing visual screening or HPV screening in their national programs. And that is after repeated bombardment and so much of noise and so many players coming into it's a concerted action. And then the vaccination came in and things like that. So everywhere people were shouting cervix cancer, cervix cancer. I think it took such a long time. And so I think it is time, one has to be patient and one has to find suitable leaders, one has to find first ladies, one has to find, sort of very politically powerful people. So I don't think, this is the major thing, I think. I think in Zambia it is the first lady, you go to Jordan, it is the princess. So many of these people, sort of key opinion leaders and people like that convinced with the evidence and then going and striking. Probably that works. And then, being part of WHO, I think WHO has a major role. Even now, when WHO makes a statement, it is received with considerable respect and attention because it's an international working party which makes such recommendations. I think in a globalized world, WHO has an increasing relevance. I think, for countries to adapt and listen to evidence and in development of policies.
Dr. Sankar, it's been a real pleasure. I know we've been planning this for a while, so thank you so much for coming. Just a little token of our appreciation.
Thank you very much. Thank you.